The purpose of this concept map is to clarify the meaning of the concept fear as experienced by the pregnant women with opioid use disorder. As both a maternity nurse and an educator, I was drawn to this particular area of interest because oftentimes we care for these women without truly understanding their perspective and prevent a holistic approach to care. Opioid use disorder is a chronic health condition characterized by tolerance, craving, inability to control use, and the continued use of opioids despite adverse consequences. The population studied here are pregnant or newly postpartum women. They either used legally prescribed medication for treatment, misused prescription medications, or engaged in illicit opioid use while pregnant. The bottom right-hand side of the screen shows a graph from the CDC showing a reported 333% increase in OUD during pregnancy from 1999 to 2014. So why is this concept of fear so important? When examining the literature, fear is often described as a barrier to prenatal and effective postpartum care in this population. The consequences of this can lead to a variety of complications that we will examine, including poor birth and neonatal outcomes, fetal or maternal death, complicated births, unintentional overdoses, and many others. First, however, we must identify fear. Fear is the experience of an unpleasant emotion caused by the awareness of danger and the adaptive ability to extrapolate knowledge from those adverse events and apply it to similar encounters. The terms fear, afraid, fearfulness, and panic are used interchangeably throughout the literature. Related concepts include concern, worry, anxiety, unease, fearfulness, angst, panic, discomfort, terror, and fright. As for measurement tools, patient narratives are used nearly exclusively throughout the literature, as there's no real specific tool found to measure this population. The closest measurement tools found were the Distress and Tolerance Index, used to predict substance abuse by identifying abilities to tolerate distress, and the Perception of Pregnancy Scale, which quantifies attitudes and perceptions of pregnancy, but is not designed to measure fear, nor is it used in the postpartum population. When looking at fear, there are three pathways have been identified as related to fear acquisition: conditioning, repeated exposure to noxious stimuli, and the transmission of information, or lack thereof. So looking at the concept map, one can see how the combination of fear. Pull it up a little bit for you. The combination of fear, pregnancy, and OUD have several undesirable outcomes. It should be noted that socioeconomic disparities, such as unemployment and poverty, add to feelings of fear. OUD users are more likely to have close friends and family members also battling OUD, which can lead to misinformation and increased fear. This is one of the antecedents of fear acquisition, along with conditioning or one's personal life experiences that have contributed to fear over time. Fear stigmatization can lead to inadequate care, social isolation, pregnancy denial, altered maternal-infant bonding, and increase the risk of birth complications and the risk of postpartum depression. Fear of detection related to opioid use can be contributed to the concern for Child Protective Services involvement, the chances one may lose custody of their children, and/or the prospect of facing legal prosecution. Remember, again, oftentimes these women have friends and family that have also used opioids. So with that comes some misinformation, anecdotal stories, as well as fear of being stigmatized by healthcare workers. Fear of detection can also lead to late prenatal care, suboptimal nutrition during pregnancy affecting the growth of the fetus, birth defects, or the fear that one's drug use will cause birth defects, as well as complications during the delivery. Other complications and consequences of fear that we haven't quite touched on yet are related to pain control in the interpartum and postpartum periods. Studies have shown due to the fear of relapse or stigmatization, opioid-dependent mothers experience more pain, whether it be from the refusal of pain medication or the denial of pain medication by the prescriber. Prescriber concerns and their hesitation to treat pain in this population are related to tolerance and the risk of overdose, or the fear of contributing to one's relapse for those that are in recovery. When looking at the treatment options of opioid use, I'll pull back here a little bit, When looking at the treatment options, it's been found that those facilities which provide medication-assisted OUD treatment, such as methadone clinics, might not be the same facilities, and oftentimes aren't the same facilities or even near the same facilities that provide prenatal care, which complicates care coordination, especially for those of low socioeconomic backgrounds. What this does is it forces many people to choose between getting treatment for their substance abuse or face with withdrawal and possible death as a consequence of not getting that treatment, or choosing prenatal care. Very rarely are they able to do both without care coordination, which is the healthcare worker's responsibility to help them with. Because scientists have difficulty replicating fear-inducing conditions, fear is a difficult concept to study, partially because of the lack of measurement tools, partially because of the subjectivity in which nature is, that fear-inducing conditions are hard to replicate all around. However, as a chronic illness, opioid use has been labeled a public health crisis. Rates of OUD in pregnancy have more than tripled in the last decade and are still rising. It is clear that fear is often a contributing factor to one's care. Healthcare providers often provide barriers to care rather than assistance. So the underlying conclusion to this whole presentation is that education, understanding, and care coordination are necessary to provide holistic, compassionate care to this growing population. Thank you for listening.